Hello.
Hello.
Can you hear me okay?
How are you doing?
I'm doing well. Just finished a few patients here. Had my lunch, so I'm ready to go.
All right. Well, it's good to have you. Thank you for joining.
Yeah.
For those who don't know, this is Dr. Baxter. He is a pediatric dentist in Pelham, Alabama. He owns the Alabama Tongue Tie Center, and he specializes in, I know tongue ties, but I'm assuming all oral ties. Is that right?
Yeah. Tongue, lip ties, buccal ties.
Okay. All right. Well, we're glad to have you. So I do have a couple of questions that were asked, and then I'll just kind of let you talk and kind of explain oral ties and the risks and
Sure.
kind of what you do. Okay.
Yeah.
All right. So the first question is, what do you say to people when their pediatricians say this is a fad and it's not necessary?
Yes, we do hear that fairly often. Not as often as we used to. I think it's getting around. Like we send out a letter to every pediatrician that refers to us, or if they didn't refer them to us, just whoever was treated by us, and let them know what we did and what improved and stuff like that. So I think we're getting better, at least in our area, although we still hear it a lot of times. So I think education is the key for that. But yeah, it's been around since biblical times. So Mark 7:35, the string of his tongue was released and he spoke plainly. Some of the earliest Japanese writings actually talk about tongue tie. King Louis the 14th, I think. I can't remember which Louis, but one of them was released in the 1600s, has his tongue tie released. So it's not like a fad. It is increasing, though, in awareness. It's also increasing in incidence. So kind of like autism, right? Autism, used to be very rare, and then it was getting more and more. It's like almost exponential now,
right?
Due to awareness, but also, something's going on. We don't know what it is. It's not just like a genetic component. Tongue tie is not different. There's increasing awareness, certainly, but there's also increasing incidence, which could be genetic, could be epigenetic. So it could be folic acid. That's one of the early, newest theories I've heard, that possibly folic acid, which thickens up those midline tissues, so you don't get heart defects, you don't get spina bifida, right? Might thicken up those midline tissues on the lip and tongue. And so, and there might like an excess of folic acid. So some people might have, just the right amount, like 600 milligrams, or I think micrograms, milligrams anyway. But a lot of people, it's 1,000, 1,200, plus it's in your food too. So I think there's an excess of folic acid and no one's really checking. MTHFR kind of plays into that as well, folate versus folic acid. So for reasons unknown, it is becoming more common. It's not a fad. It's not just to pay for the laser or whatever pediatricians like to say. Haters gonna hate,
Right. I think that's with everything, though. There's always going to be that one group of people that are just totally against what you're saying, regardless of, they can know nothing about it. Like it can be something they don't know anything about. And it's just, they're always going to have something to say.
Yeah, it's frustrating. I think it comes down to like a lack of education. For breastfeeding, they only get 2 hours or 4 hours in the whole residency of pediatrics, which is about 3 years. And so tongue tie, they probably get maybe 2 slides. Like we did in dental school, we got 2 slides or 1 slide on tongue tie. That's it. As a dentist, it's right there. Again, it's probably 20%, maybe 25% of people have a restrictive tongue tie that's causing a problem. And so, it's hugely misdiagnosed, underdiagnosed. And so we really try to not overtreat or undertreat. We try to get right in the middle.
Okay. All right. My next question for you is, what is your optimal age for a release?
2 days old.
2 days old.
1 day old. We've had one day old. That's a funny story. Actually, maybe if we have two, we've had 2 1-day-old babies. They were home births because you don't normally get out of the hospital that soon. But they're like, oh, we were just out running errands. Thought we'd come get the tongue tie done. It's like,
okay.
As one does, I guess, when having your 5th child at home, you're just like, oh, we're out running errands the next day, and thought we'd come get the tongue tie fixed up.
I guess the sooner the better, though, especially if you're breastfeeding.
It is. It really is. They don't take so long to have bad habits. So I say tongue in cheek, but Yeah, so basically, like our daughter Molly, I asked if I could bring the laser to the hospital. They said no. I said, well, that's understandable. I don't have privileges at the hospital. I can't do procedures there, so that's understandable. But what we did on the way home from the hospital, we didn't even go home. On the way home from the hospital, we stopped and did it at the office here, and right away she nursed immediately better. We had the lactation consultant come to our house that first week, saw the chiropractor the first week, and had craniosacral therapy for Molly the first week. And she's 22 months and nursing like a pro. And yeah, still like loves getting her milk and more milk, mama, please.
Yeah.
So sweet.
Oh, sweet.
It's wonderful how that nursing relationship versus with our twins. You know, it was probably two weeks ish when we like thought they might have a tongue tie. Asked the pediatrician. She said, "I don't see one, but I'll clip it if your lactation consultant wants me to," which is not the correct answer. We were so sleep deprived, we didn't know. Like, okay, that sounds good. So it didn't make a difference. And then I was like, well, maybe that wasn't the problem then if it didn't help. So maybe it's something else. Like they're still a little bit early, you know, premature. They were twins, but they were 38 weeks. They were good. Small mouth, some other factor. So really, what we didn't know was that it was just clipped halfway. So like if you have syndactyly, like your fingers stuck together, they basically just cut it like that. So your fingers are still stuck together. So what we do is we get a full release. So we went and saw the dentist. It was up in Ohio, Dr. Notstein. He did a full release on them, and then they nursed much better after that. But still had issues, and my wife ended up pumping for like a year with twins, which is a lot of work.
Yeah.
So huge difference with Molly. We did on day 2 versus the girls was really fully released at like 5 or 6 weeks old. So.
Okay. All right. Someone said, what is his view of suck training, and what does he recommend for suck training for pre-release preparation, and for how long?
Sure. So, I mean, just this morning, I recommended to one of the moms, they're still having like a hard time after a week to look up. Basically, I just say like check YouTube for some infant suck training videos. I know there's probably 1,000 out there. I'm not a lactation consultant, obviously. So I don't know. So take what I have to say with a grain of salt, but I think it's definitely important to help rehabilitate the baby. If you can do it beforehand, great. That's even better. Just like with adults, you know, you want to do myofunctional therapy first, or with kids, you want to do myofunctional therapy first, or at least speech therapy or something, get them awareness of the mouth. I think that's helpful with babies, but I wouldn't put the release off just so we can do 2 weeks of suck training first, if that makes sense. But if you're like, it's going to be, you know, a few days or a week or so before they can get you in, then it may be helpful to do that in the meantime. And then definitely afterward as needed, but work with lactation consultant for that.
All right. Okay, so I have one more question.
Sure.
Can you speak on using coconut oil for stretches? Some providers say this quickens wound healing, which we don't want, and others say it is beneficial for stretches. Does that kind of relate to what
whatever the parent wants to do, it probably doesn't make a big difference either way. So we have some moms that really want to use coconut oil. I say, great. It looks like it heals nicely. Mm-hmm. We have moms that don't, and it looks like it heals nicely too. So it probably doesn't make a big difference either way. So whatever mom feels comfortable with, if you feel like it helps you get in there better, the key to the stretch is really getting it in the right location. So if this is the tongue, you're going to flip the tongue. Sorry, it's like a beard. Flip it up, and then there's going to be a diamond shape under the tongue. Push it down is the key, and then back, and really put the tension on it. And then also just right behind the gum pad, kind of massage up the tongue, really just right on the wound. You don't want to do it too hard. You know, you can push too hard, but most people we see are just barely pushing. They're just not really, you got to really push into it because what we're trying to do is trick it to heal open. So most of the time we want wounds to close. That's a good thing. Like if you cut your leg or cut your hand or something, you want it to close. But like if you get your ear pierced, you don't want that to close up. So you wear the earring. So it'd be like the same thing. Like if you got your ear pierced, but then you left it out, but you put it back in like 4 or 5 times a day, you can probably keep that hole patent. It's the same concept. We're just trying to get it to trick it to heal open. And so by doing the stretches 4 or 5 times a day, I say quality over quantity. So a high quality stretch, 4 good ones is better than 6 mediocre ones.
Right.
3 good ones is better than 7 mediocre ones. So. Okay.
So we have a couple of live questions. You okay with answering those? Do you have?
Yeah.
Okay. Let me see.
Last time I did this was in French. That was much harder. This is much easier. I don't speak French, but the question came in French. They have to translate both ways. So this is
All right. So I'm just going to post the question on here. All right. Are there any plans to do more long-term studies on the benefits of the release?
Not that I know of, but that's a really good idea. I'll write that down. So we need to have more long-term studies. Write that down. So we have like a bunch of data for babies that we treated like a year or two ago. I need to have like some, I have to get IRB approval. Like it takes a lot to do research. Might be my project for next year. Try to get like a survey to those moms and see like how they are with their speech, their solid feeding, their sleep. And then we'd have to get like a control group. That's what's hard. Finding kids that are tongue-tied but never got it fixed. That's pretty difficult to do. Otherwise, they'll say, oh, there's no control group. They would have gotten better anyway. It's like, well, not necessarily. So that's what's really hard about research is having a control group. That's nice for like the vaccine studies, for example, with like COVID. That's perfect. Or like a drug, you give these people get a pill, these people don't get a pill, you can compare them. Mm-hmm. With babies, it's not really ethical to say, hey, they have a tongue tie. We're not going to treat it because we want to see what happens and how bad off they are. When we know it works, like you see it right in front of you. It's like you put a turkey in the oven and it's hot and it cooks. Like it's that obvious. So yeah, we need more research, of course, but at the same time, we have to go with what we have, which we do have enough research, I think, to go on. There's some good level 1 evidence, randomized control trials on tongue ties. There's some level 2 evidence, cohort studies. Dr. Gahari's in particular talks about lip tie. O'Callaghan talks about lip tie. And then for buccal ties, there's not really any evidence. And so, like for us, and this is not the question you're asking, but for us, we give the parents the choice if they want to do the buccal tie or not. If it's tighter, if it's restrictive, you feel it and it feels like a speed bump up in the cheek. But the problem is like there's not a lot of symptoms I can point to say, okay, right here, acid reflux, that's from the buccal tie, or can't hold a passy, that's from the buccal tie. Those are from tongue or lip or whatever, but it's hard to say like, okay, that's a buccal tie issue. And then there's no research on buccal ties. So we don't charge for treating buccal ties. We always leave it up to the parents, but we try to base everything we do based on research for sure. So we need more.
Okay. Well, that was actually the next question. Do you have these buccal ties and what would be the conditions to require that? So
yeah, that mostly touched on it. I mean, again, there's not like we have a symptom form. I don't have one with me right now, but there's a symptom form. Here's like all the symptoms that we commonly see with tongue tie. Mm-hmm. For babies, and we have another one for children and adults. But like, there's nothing on there. I'd be like, okay, like colic, that's from buccal tie, or whatever it is. Nipple pain, like that nipple pain's probably from the tongue. Colic's probably from swallowing air. That's probably a seal issue. So maybe it could contribute to the seal issue. So what we normally say is the tongue is probably 60% of the problem. Mm-hmm. The lip tie is probably 30, maybe to 40%. And the buccal tie is probably 5 to 10%. So the tongue is primary. The lip is secondary. The buccal ties, those are tertiary.
Okay. Well, that's all the questions we had. So if you want to just kind of elaborate, well, you kind of already did on the laser versus, I guess, cutting and anything else that you want to elaborate on yourself?
Yeah. Talk as long as you want me to. I talk all day. So yeah, for the lasers, so basically all lasers are not the same. There's 3 main types of dental lasers. We'll talk about in a second. The earliest methods were scissors. So scissors have been around for a long time, obviously. Like the articles in the 1600s where they talked about the king's surgeon M. Guilleminot released Louis XIII's tongue tie was with scissors up until 1900s and still used today. Like Dr. Zaghi used scissors. He uses the CO2 laser now, but he still might do some scissors releases too, I'm pretty sure. Dr. Gahari used scissors for a long time. And so it's more ENTs, pediatricians using scissors, but it can be done with scissors well. It's not just one cut in the middle. You have to do smaller cuts. Dr. Gahari says it's like uncasing a sausage. So just do small little cuts down the side of it, about 4 or 5 times, and then use your finger to kind of feel it. And you still get that nice diamond shape. There's not a ton of bleeding, but there's some bleeding. Scalpel would not recommend. It's very sharp, obviously. And if the baby moves at all, like and scissors too, if the baby moves at all, like you're going to cut something you don't want to cut, or possibly. There's some vessels, there's nerves down there. There's, obviously the veins, arteries, nerves. So you don't want to cut that. But with the laser, it's really nice because it looks like a pen. And so basically it just kind of hovers over it and it just disappears. And so if they move, it moves a little bit, but it's pulsing, right? 29 times per second. So kind of like a tattoo, but faster. And so it's pulsing. And if it moves a little bit, you put like 1 or 2 little dots over there, not a problem. But if they move, you just lift your foot off and it stops. So some people say, oh, the laser is so dangerous. It's a laser, class 4 surgical laser. But the way we're using it at like 1 watt, it's very, very safe and effective with good eye protection. We follow all laser safety protocols. We have suction there to suction up it has a little, like, it's called plume, but it's like a little smoke because what it does is it vaporizes the tissue. So the 3 types of lasers, there's diode laser. That's what we started out with. I don't see it in here. Sometimes it's in this room. I'll show you, but it's really small, like a pen. The erbium one has a pen handpiece, but then it goes to a bigger unit. And then CO2, same thing. It has a handpiece that goes to a bigger unit, but the handpiece looks just like a pen. But the diode laser, like, it's literally like the size of a pen. And what it does is it heats up a tip to like 1,000 degrees Celsius, so 700 to 1,000 degrees Celsius, which is white hot. And then you stick that tip on the tissue, and that's what does the cutting. So you're basically burning the crap out of it. And that does not feel good, as you can imagine. It's very, very hot. It hurts the babies more. It seems to have more post-op pain afterward. And also it takes much longer. So a diode laser release is probably closer to a minute per area. It's like a minute for the lip tie, a minute for the tongue tie. Some are faster. So if it's a hotter laser, basically, there's one called the X-Lace that's more expensive. But the normal diode lasers are $3,000 to $10,000, probably in that range. The erbium, so those are good at coagulating, right? There's not much bleeding with the diode laser, but they're slow, and you're not using it as a laser, right? You're blocking the laser energy with a charred glass tip, and that tip gets white hot, and that's what's used to use the cutting because you have to touch it to the tissue physically. The other 2 types of lasers are erbium lasers and CO2 lasers. Those ones, you just hover over it. You don't actually have to touch it. And the laser energy is actually, as a laser should, interacting with the tissue, causing the desired effect. And so basically the photons are coming out of the laser, hitting the water molecules and exciting them to 100 degrees Celsius. That's the boiling point of water. So 10 times cooler. It's still not cool, right? It's still like 212 degrees Fahrenheit, 100 degrees Celsius, but that causes the tissue to vaporize. So it just turns to steam and it just disappears. Why that's important is it's a gentler method. So you're lifting up on it, pulling away, and then it's just barely nicking the tissue, and then just kind of opens up as you're lifting up on it. So typically still don't get much bleeding with the CO2 laser. With erbium lasers, you can get some bleeding. But yeah, that's the difference, and they're much quicker. So the CO2 laser, instead of a minute per area, is about 10, 15 seconds for the lip, and the tongue is about 5 or 10 seconds, and minimal bleeding. Erbium is also pretty quick, but you're going to get more bleeding just because the wavelength is different than the CO2. So those are the 3 types of dental lasers, probably more than you guys wanted to know. The key is just ask them. If whoever's doing the procedure cannot tell you what type of laser they have, that's very concerning. They should know what type of laser it is. They should know about how it works and the settings to change and all that stuff. But anyway.
Okay. We have another question. Is reattachment common after laser revision, and what tends to cause reattachment when it does happen?
So it is common. It's not normal. I guess it's normal healing, but we try to fix it. So it's funny because whenever we do like the consults with the moms, they think like reflux is normal, snoring is normal, colic is normal. It's like, no, those are common, but not normal, right? Like cavities in kids, those are common, but not normal. Kids shouldn't have cavities. So it is common after revision. And so also revision and release are 2 words that we like to talk about as well. So a release is like the first time you do it, you're releasing the tissue. A revision, whether it's a circumcision revision or a tongue tie revision, is it has to be revised. Like you're revising someone's work, you go back and fix it again. But a lot of people use them interchangeably. But so it can grow back together. It's just part of normal wound healing. So that is normal. In our office, how often do we have to re-release it? About 1% of the time. So 99 times out of 100, parents do great stretches. The baby has good wound healing. We see them back in a week and it looks great. Or we have to do a deeper stretch, kind of stretch on a little bit more just to make sure it's not sticking back together. And then we never hear back from them. There's no problem and they're doing great. Sometimes, so maybe 1 out of 100. So not super common, but it does happen. It's growing back and then they come and see us 3 or 4 months later. I always try just to do a deeper stretch. Sometimes like on a baby, it'll work, not on the lip as much, but on the tongue because the tissue's not fully grown back together, right? It's healed on top, but not below. So we'll just push on it and it'll just open right back up without a laser or anything. And so we prefer that because then they do stretches for about 2 weeks maybe, and then it's closed. If we have to re-release it with a laser, we don't charge, but they have to do the stretches for 3 more weeks. And then we'll see them back like weekly to check on it, make sure, because we don't want to do a 3rd time. We've had some babies come to us a 4th and 5th time that had a release and release and then 4 revisions after that. And it might have been some incomplete ones with scissors or scalpel or electrosurge or sometimes with a laser, and it still grew back together. So the keys to like minimizing reattachment, we have a lecture on that a few years ago, but it's about getting the patient back for follow-up. That's really important. So most of the time, like an ENT, for example, or maybe some dentists wouldn't get them back for follow-up. Follow-ups don't pay anything, but that's the best time because they tell you what improved. You get to see what got better. And also you can check on wound healing. So if the wound is sticking back together, you can just do a little bit massage and you don't have to push very hard and it'll open back up right then. And then you're done. Recommend for parents to push a little bit harder under there. And then you have less likely to reattach for the follow-up for the next 2 weeks. And then also we've started having parents put on gloves while still in our office. After they nurse, we'll have them put on gloves and practice the stretches after we show them. So we show them the stretches, then have the parents put on gloves, have them get behind the baby and do it. Because if they don't feel comfortable with it, they're not going to do it when they get home. Right. So it's really important to make sure that they know how to do it, because we make it look easy. We do it all the time. Oh, lift up the lip, lift up the tongue, done. It's like once they get in there, like, ooh, hello, like this is harder than it looks, and they don't want to hurt the baby. I don't either, but I also don't want to have to re-laser it again in a few months. So
it's important for them to feel confident and knowing how to do it, rather than, it's different than hearing somebody say, this is how you do it. And
you want the video on it, you can hear it, you can see it in person, but then once you put on gloves and physically do it, there's a lot of coaching that needs to take place. And often Ashley, kind of our administrator for the tongue tie center, she does the stretches afterward. She's really good at it and she can show them how and then coach the moms through it. But it's an emotional time. I mean, like they're postpartum, often if we're talking about babies, they're stressed out, and the baby just had a procedure, and for us it's not a big deal. Like we do it all the time, but for them it's a huge deal. They might have traveled several hours to come see us, and it's a lot of money, and there's like all these emotions. And then you're asking me to get my kid and make them cry after we just calm them down. Like it's hard. That's by far the worst part. If they ever figure out like a way to not do stretches and have it heal nicely, so that'd be wonderful. So if there's a better way, we definitely do it. We've tried the surgical super glue on kids and adults. It doesn't seem to work. Sutures does work pretty well on like adults, but to do it on a baby, we have to put the baby to sleep, and that's not worth it. That introduces a whole lot of extra risk. And we could only do it, twice a month at Children's Hospital. That's not enough. So anyway, I think the key is just getting their high quality stretches. And so we now say 4 times a day. If you tell parents 6 times a day, they're going to feel like a failure if they can't get in 6. Mm-hmm. So we say 4. I mean, if you do 3 one day, not a big deal. Like just try to space them out, high quality, really get in there, focus on getting that one stretch right, and then wait several hours and, till the middle of the day and do it again. Because, with my daughter, Molly, don't tell anyone, I only did stretches twice a day. I was working, so I did it in the morning and the evening, but I know how to do high quality stretches every time, and it did not grow back together. So the quality is more, it was kind of like a test. Right. My own kids, right? See how few stretches can I do? Because I don't like making her mad either. A sweet little baby. Welcome to the world. Here's your stretches, but
now.
But if so, like 3 times a day is even fine. I don't think you have to wake them up in the middle of the night to do it. That's not reasonable. We really try to hey, like what's common sense here, or what can people actually accomplish? I mean,
Right.
we've done studies like asking parents or asking an adult to take a pill 4 times a day, your compliance drops off like exponentially. As if a pill once a day versus twice a day versus 3 times versus 4 times. That's why people write for amoxicillin is 3 times a day versus Augmentins versus 2 times a day. And then like dicloxacillin, if you get mastitis, I think it's 4 times a day. So like that's asking too much people to do 6 times a day or 8 times a day stretches. So I think for babies, 4 times is reasonable. For toddlers, we recommend twice a day. And then for like adults or like older kids, we'll say 3 times a day normally.
Okay. All right, let's see. Are there any times you would use scissors rather than a laser?
So no, I've actually never done a release with scissors. I take that back. If I was on a mission trip in Africa, which we do, like we went to Ghana for a trip, Haiti, Myanmar for mission trips. If I was on a mission trip and saw a tongue tie, we have scissors with us, surgical scissors, then I would consider doing it then with scissors. But in the office here, as long as my laser is working, I would use it, even if the power went out. So back to the story with Molly, our daughter, who's almost 2, we came on Sunday afternoon to do the release. Just on the way home from the hospital, the power was out. I was like, oh my gosh, of all times, the power's out. And the lasers, obviously, you have to plug it in. Got the battery backup off the computer, plugged it in, and we did it with the battery backup. It gave enough juice for the laser to work. So even if the power's out, we now have a battery backup dedicated just for the laser. So yeah, if my laser for some reason didn't work, I would go back to my backup, the diode laser. If that didn't work, then I would do it with scissors. And I think we can still get a good release with scissors, but it's going to bleed more. It's harder to get a good release for it. It's not rocket science, right? Like it's easier to do a filling than to do. It's easier to do a tongue tie than it is to do a filling as a dentist. A lot of people don't realize that. So the procedure itself is pretty easy. It's all the stuff around. Like what to do afterward, what to do before, when to do it. Like, is this patient a good candidate for it or not? We don't just laser everyone that walks in. What to do if there's complications. So that's what's harder than just like, clipping them with scissors or even using the laser. Like it's not too hard once you get the hang of it. I would use the scissors if I was on a mission trip, or if both my lasers were not working, I would consider using scissors because we wouldn't want to send someone away if they've driven several hours to see us. And that's hard. Good question.
All right, we'll get this last question in, and then if you have anything else you want to say, you feel free.
Yeah.
What is the recommendation of a mama that is still experiencing pain, but baby seems to be eating well and gaining weight?
Great question. Perfect. So it's based on, whether to do a tongue tie or not, it's based off of 3 things. So get off from my mirror here. So 3 things. One is the symptoms, and that's the most important aspect is the symptoms. So what problems is it causing for mom and baby? So if they're refluxy, gassy, spitting up all the time, they're constantly eating, like never feel full, it's a full-time job for mom, milk's leaking out of their mouth, the lip curls under, shallow latch, like all those things are baby symptoms for mom. If it's painful, if like creased, flattened, blanched nipples, lipstick-shaped nipples, blistered, bleeding, cut nipples, mastitis, engorgement. I'm just running down the list in my head. I think I've gotten most of them. Having to use a nipple shield, it hurts worse on one side than the other, or baby prefers one side over the other, and then like clogged ducts or clogged ducts. So those are all the mom symptoms. Oh, and then like not emptying, so if the baby's not getting enough milk. So that's a quick rundown of the symptoms. It's on our website too. So what symptoms is it causing? So weight gain is only one of those symptoms, right? I don't think I even mentioned it. Weight gain is one of the symptoms. For the pediatrician, that's the symptom. Not to rag on pediatricians. They are an easy target, but one symptom is weight gain. But then we have some babies that have every other check mark, but they're gaining weight well. And so for those babies, we still recommend a release. Why? Because we know it can help with those other symptoms I just mentioned. Plus, in the future, we think, and studies have shown, that like speech later on, solid feeding, sleep, I mean, those are really key areas, like sleep quality, solid feeding, not slow eating, picky eating, spitting foods out, that kind of stuff. And then speech, R's, L's, S's, SH sounds, speech delay. We have a lot of kids that are tongue-tied have speech delay. After it's released properly, they have new words after the procedure. And so it's protective if you do it as a baby for later on. So there's a lot of benefits and not many risks if the procedure is done properly. And so we got to make sure that we're looking at the whole picture, not just like, oh, he's gaining weight, you're good. So if it's still painful, I'd ask, look at all the other symptoms that if the baby's still gassy, here in Alabama at least. Where are you, Kayla? Oh, I think you're muted. What'd you say?
I'm in Anniston. I'm about an hour from Birmingham.
Yeah, so like in Anniston. Yeah, so like in Alabama, I don't know. A lot of the parents, they probably took this like, he treats like a grown man. Like the baby's supposed to like have that much gas basically, and they're uncomfortable and colicky. And so what's really key is that you have to look at the whole picture. So if it's causing pain and they're gassy and like he's not getting enough milk or constantly eating, but they're gaining weight, then it's still probably worth doing. So I'd probably say half the patients that we see are having weight gain problems, but half of them are not. Maybe 25% are purely bottle feeding and they're gaining weight. Okay. And so again, it's not like, oh, if they're not breastfeeding, just give them a bottle and they'll be fine. No, we have a lot of bottle-fed babies that are still having lots of trouble with the bottle. We had one this morning that's still not gaining weight. He can only take 3 ounces, I think. He gets too tired out because it's so much effort for him to get milk. Tongue-tied babies get about half as much milk per suck as a non-tongue-tied baby. So they have to work twice as hard to get the milk. So when he's just taking 3 ounces, it's like he put the effort out to take 6, and they just fall asleep. And so it's a really common problem. And unfortunately, there's not like good education on it. So there's a couple of pediatricians, even like in Anniston, we have one that sends people to us if there's a tongue-tied baby. But most of the time, it's not picked up. And so you really have to do like your own research, like people that are watching this podcast. So glad you're here.
Okay. So I did get 2 more questions.
Great. I'll just keep talking till the questions come in.
But you let me know when you have to go because I know you're on your lunch break. So.
Probably about 12:45 or so. But
okay. All right. What helps determine a release for adults?
Great question. So these are all the baby symptoms we've been talking about because this is about, bump, birth, and beyond. I guess we'll get to the beyond part here, down the way a little bit further. So our child symptoms and then the adult symptoms. So child symptoms, we talked about, there's 3 main areas: speech, solid feeding, and sleep quality. And then we have an other on our form too. You can download our forms at tonguetieal.com and you can see all the symptoms listed out for you. So speech, solid feeding, sleep. The other is like stuff like hyperactivity, inattention, ear infections a lot, enlarged tonsils and adenoids, strong gag reflex. And then it has the adult stuff. So the adult stuff is like neck tension, shoulder pain, headaches, migraines, TMJ problems, grinding the teeth at night or clenching, and then the sleep issues. So as an adult, most adults have figured their speech out, at least to a certain extent. They can sound like they're making the right sounds, even if they're not have the correct placement. So like for me, I back all my L's. La, la, la. I say with the back of my throat. You're supposed to say with the front. La, 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 like that. But after 30 years of having a tongue tie, I talk with like that. And so there's only one correct placement for each sound though. So adults, even though they might sound correct, they might be making the sounds incorrectly. But most adults don't have the speech issues, but some do. Swallowing pills, trouble swallowing pills. And then you get to the neck tension, shoulder pain, headaches, migraines, and sleep. So sleep is one area that is harder to fix. Sleep is also multifactorial. So it could be caused by like sleep apnea, for example. It could be if you're heavier, but it could also be if you have large tonsils. It could also be if your tongue is held down, okay, from a tongue tie, it's falling back or flopping back into your airway and choking you while you sleep. So you can't get as much oxygen, or it narrows the airway if it's not fully obstructing. And so often the adults will have, like I said, TMJ issues, sleep issues, trouble swallowing pills, sometimes speech issues. They get tired when talking, or if they have to talk a lot, like reading out loud to their kids. I used to get tired when doing that, and I didn't like doing it. So anyway, but after the release, now I can talk all day and talk as fast as I need to. But I used to wonder, like, how do people talk that fast? Like, I could never talk that quickly, and I would get tired when doing it. So now I talk all day, and I don't have TMJ problems anymore. So
okay. Can buccal ties be released with scissors?
Yes, you can. So again, the cheek ties, buccal ties, some people say buccal ties. Basically, We use the laser. It takes about 4 or 5 seconds. There's no bleeding. You could clip it with scissors as well. It'd be a couple small cuts. There's no really good research on them. There used to not be good research on lip ties either. Some lactation consultants swear by them. It seems that they can help with nipple stabilization maybe. Kids with dimples, so if you smile and they have dimples, those people have buccal ties, which is an interesting fact. Yeah. And then it can cause a gum recession, like in a teenager or an adult. Can make it harder to brush your teeth. You can't pull out the cheek as easily. So there's some issues that seems to be caused by buccal ties, but again, there's no good research on it. But yeah, if you want to do it with scissors, you could do it with scissors. But most ENTs would just look at you like you had 2 heads if you asked them to release your child's buccal tie. Like most of them won't even do a lip tie. And most of the time, at least again, in Alabama, the ones we see coming to us for a second opinion or something after it's been done, they clip halfway. So that's at the hospital or the ENT, they just cut it halfway. So if there's not a nice diamond shape under there, then it probably was not released fully. And most of the time when it's clipped at the hospital, not all, but most of the time, they don't tell the parents to do the stretches. That's like going to the mall, they pierce your ear, and then they never tell you to wear the earring. Like it's going to close up. Like it doesn't take, an MD to know that, like, okay, if you make a cut on the body and just leave it, it's going to close back up. So anyway.
My son had, he's 9 months now, and he had a severe tongue tie, they said, and Dr. Caballero here in Anniston clipped it, but he never told me like to do any stretches or anything. So. Yep.
And I love Jose. He is actually the only pediatrician that has come see us here at the tongue tie center. Well, take that back. We had one from Ireland come visit. But like locally, he's the only one that's come. He spent a day with us here, like learning more about it. He was very interested in it. So yeah, Dr. Caballero is great. But he still sends them to us sometimes for tongue tie release if he feels like he can't get it all the way or whatever the case may be. But yeah, I think he knows now to do stretches in the last couple of years. But yeah, he's really nice. I like him a lot. He's a good guy. So like, yeah, just make sure that they're doing it all the way. Come see us if you have any concerns or questions about it. I mean, we've seen some come from RMC even that were clipped into the salivary glands, right? Not by Dr. Caballero, by someone else, but they're cut into the salivary glands. We've seen one that was cut into the body of the tongue from RMC. And so like they missed the frenum, they missed the string completely and got it. So when I do it, my glasses have magnification on them so I can see what I'm doing. I have a bright light. So, I can see, it's a dark hole, that mouth. And so we want to be able to see exactly what we're doing. We have an assistant there helping stabilize, sometimes 2 assistants. So we really want to make sure that we have like total control and we're not just cutting blindly or anything like that. We really try to get precisely, get a full release every time, and then give the parents the follow-up and all the aftercare instructions. That's important because, again, if you don't stretch it or if it's cut halfway, it might help with nipple pain. There's some studies on that. It might help a little bit with like nursing, but it's not going to help as much as it could. And you leave the child open for problems later on because it was only done halfway or it grew back together. So.
Okay. All right. Well, I guess that's all the questions we have.
Great.
So you have anything else you want to?
I think that's all. Let's see. We have a book. So if anyone's interested, all the royalties are donated to charity. So we don't, not like making tons of money off this. But it is a bestseller on Amazon. So it's called Tongue Tied. How a tiny string under the tongue impacts nursing, speech, feeding, and more. So there's lots that goes into it. We did have a pediatrician write the foreword, had a chiropractor, an occupational therapist, myofunctional therapist, lactation consultant, and speech therapist and feeding therapist. So it's really trying to show the team approach. We've given these out to most pediatricians in Alabama. Most of them probably have not read it, but it's for parents and pediatricians. So if you like the podcast or want some, we have some here at the office, obviously. We give them out to a lot of the patients. But yeah, just trying to help educate because we need more education. We're much better than we were a couple of years ago as far as education goes, but there's still a really long way to go. So it's actually been translated into French now. I don't know if I have my Spanish version here too. It's been French and Spanish, which is pretty exciting. Like the whole thing is in French. Anyway, and it's actually a bestseller in France too. So that's why I was doing the podcast last week with some French speech therapists. So yeah, just keep working on your pediatricians, speech therapists. The therapists and like the lactation consultants would probably be more on board with it because they see the results. But the pediatricians, if every mom that got it done went afterward to the pediatrician and said, hey, this helped my child. Here's what it was like before. Here's what happened afterward. They can't argue with that. Mm-hmm. And so, we'll get to them. And then maybe they'll say, hey, there's something to that. Like we should look into it. Because what they're taught in school, which again, this is from an article from the 1950s. It says, thank you, Christy. From 1950s, it says tongue ties rarely cause problems. They often stretch out and they don't need to be done. So like, that's what they're taught. That's literally what they're taught. So it's not that they're bad people. It's just it's a lack of education from a systemic level. And it's not just Alabama. It's like worldwide. It's the main pediatric textbooks just completely ignore the subject or have false information from the 1950s and earlier. So anyway.
Yeah, it's a lot of out-of-date information going around.
Education, trust your gut, trust your mother's instinct, educate yourself, check out our website. We have lots of good resources on there, videos and quizzes and stuff like that. tonguetieal.com for Tongue Tie Alabama. Or if you just type in tongue tie or Alabama, it'll pull up on Google. But anyway, yeah, we'd love to help you. If you think your baby has a tongue tie, just give us a call. Yeah.
All right. Yeah. So anybody, if you have, any of you are expecting a baby or think your baby might have tongue ties, lip ties, go see Dr. Baxter. And Dr. Baxter, thank you again for joining me today. I really enjoyed it, and I really appreciate you taking your time out and answering all these questions. I hope everybody got a lot of information.
Yeah, hope so. Now I bet some people think, you know what? Maybe my second child had that, or because they didn't nurse well, and now they have the speech issues and the eating issues, and it's any combination of those, right? Like if you think your child has a tongue tie, there's a pretty good chance he does, because that's the most common thing. Thank you, Lindsay. That's the most common thing that causes those symptoms, right? Like we want kids to not just survive; we want them to thrive. Mm-hmm. That's a key. Like, well, again, not to rag on the pediatricians, but like, oh yeah, we've had kids for 2 years that have been tongue tied and they're fine. Yeah, they'll live, but we want them to thrive. Like C- versus A+. Like they may not get the A+. We want to give them the ability to, So anyway,
eating processed food versus whole foods. Well, I've been eating processed food all my life, and I'm still alive.
You'll live. But you'll feel better if you try to eat, healthier food or whatever, or work out, or so it's like that. But it's extremely common. It's probably 20-25% of babies. So that's what I said. Like in any classroom, whoever's the last one to finish their lunch, that kid probably has a tongue tie. Mm-hmm. He's probably also seeing the speech therapist at school and has dark circles under his eyes because he can't sleep well. And the babies that are just, he's just a fussy baby, colicky baby, refluxy spitting up baby, he's a happy spitter. Those babies most of the time have tongue lip tie. Most of the time. If it's causing pain's not normal. Right. They don't have a tongue tie.
Yeah.
Shallow latch, you try to push him on and he scoots off. It's not comfortable for him because he can't get a deep latch because his palate's hypersensitive. It's going to gag him. Or he's trying to slow down the flow so it'll pull off. It's not that he's just a bad nurser or a lazy nurser. Don't give personality traits to babies. He wants to eat. She wants to eat. So anyway. That's just for fun. I just keep going. But yeah.
I get it. I agree.
Mother's instinct. Check out our website. We don't just laser everyone. If someone just want to come talk to us for a consult, we do that obviously too. So yeah. Thanks for having me though, Kayla. Appreciate it.
You're welcome. Thank you. And I posted the website in the comments, guys. If you want to go back and check it out, get the book, schedule a consult, anything like that. All right. Well, I guess we'll let you go and have a good rest of your day. And
you got a few more this afternoon. Yeah. So, let's see, 6-year-old, 1-year-old, no babies this afternoon, and a 5-year-old almost. So, and then a couple baby follow-ups. But yeah, we stay busy, so that's good. We're having fun.
All right. Well, thank you again, and enjoy the rest of your day.
Thank you, Kayla. Appreciate it. Thanks, guys, for listening. Take care.
Bye. All right, you guys. Yeah, so I hope everybody got a lot of information. Thank you again for joining. If you have any other questions, like I said, I posted the website in the comments on my page. So I'm pretty sure he has a place on there where you can go and ask questions, send him an email, all of that good stuff. So I appreciate you all taking your time out and coming out. Or you didn't come out anywhere, but taking the time out of your day to sit and join us. And I hope you all got a lot of information. And I hope you all enjoy the rest of your day.